into a molecular tumor board. So I've changed it a little bit. It's not like, affording patient, non-affording patient, because there's so much of confusion about the entity, its utility. And I've chosen today prostate cancer because that is even more confusing. If you look at NCCN guidelines, it looks like every second patient, that kind of patient that we see, requires genetic analysis if you go by NCCN guidelines. But in reality, I think barely 5 or 10% of prostate cancer patients have, not even 5%. So are we missing something, or is NCCN sort of going overboard? And I'll also show, so that's why what I want when I'll be presenting this, because we have experts here, the names are here and it's already been said, represents the whole of the country. There have been surveys in US. So in US, a lot of urologists or uro-oncologists treat prostate cancer. Even they think very differently, and people have not come to grips with the NCCN. No one would know. I mean, it's not possible. Even I don't remember all the NCCN guidelines for prostate cancer, so no one is expected to know. But I think if you think logically and then see what is applicable. Okay. So the issue that we need to discuss: do molecular tumor boards improve clinical outcomes? Is it just one more exercise in futility? We just spend time. Then, do you believe in precision of N of 1 strategy? Clinical context: when molecular aspects of prostate cancer are relevant. Pathways and genes to be evaluated as per clinical context, because that varies. Which test, germline or somatic or both? A lot of people are confused and they ask me, "Yaar, kya karne ka? Germline kare ki somatic kare?" And and then what to use for somatic testing? The patient had a prostate biopsy, so many course biopsy. Either that when patient has metastasis, or you biopsy the metastasis, or you use cell-free DNA, use liquid biopsy. Then what do you do if your patient doesn't have access to or not willing to go to expert genetic counseling? And that is very common scenario in India. So the doctor who has ordered for the test, they get sort of stuck with the patient, because you have ordered for the test, you are supposed to guide the patient. So what do you do? So we also request voting. If you all, at least the experts and others also could scan. So I am asking, this is now for all solid tumors. This is not for prostate specific. So either you felt the need, or you actually use a molecular tumor board and or genetic counseling in your practice. So in what percent of solid tumor patients you have, in whom you have done a somatic NGS panel or a pathway specific assay or a liquid biopsy? It could be anything from in your local hospital to foundation on whichever test you have used. I feel the need for molecular tumor board guidance. So any people would like to vote? At least the experts should vote, the panel, because that is how you all are. The organizers, how to vote. I was told they have to. Okay.
So there is a QR code on each table. You can either scan that, or you use the HTTPS link that is being shown. It is www.45thicon.com/voting. Once you go to the ICON website, there are 4 options. You please select molecular oncology and then you can vote for it.
Okay. Sorry, this announcement should have been made earlier. So just scan it, open the QR code scanner. And why this is important? Because we really do not know what we want. And if suppose you want to establish a molecular tumor board, the department or the administration say, why do you need it? So you have to have some basis, not just because it should have it, just is in fashion. So we need some opinion that if you feel that in 50% of your patient you will be better off with a molecular tumor board guidance, then it means it is needed. If you feel you need it only for 2% cases, that means it is not needed. I'll wait for a few minutes. So those who have already done, they can familiarize themselves with the questions. It's done, shall we? Or some people are still doing it? Done? Okay. Yeah, so one by one. You have to, so you're expert, and there's no right and wrong, because if you look at the surveys done in US, the responses go anywhere. So this is, you're talking about, it is not a test of, and whatever NCCN write is not written on stone. So I mean, some panel there also decide what is there, and many things what the right is actually people in the practice in the US community do not agree with and do not do that. So the first question is, in what percentage? Just write the number. If you feel 50%, 90%, 5%. For solid tumor patient, somatic panel, you think a molecular tumor board could help you, or you might need that guidance. Done? Now, the next question is again the same thing, but this is for, in these patients, you have done a germline test, and here instead of a molecular tumor board, in addition to that, you need a genetic counselor's input. So that is the question number. So maybe in 5% patient, 95% patient, 100% patients, whatever is your number. Okay. So is it easy to navigate and vote, or difficult or impossible? Okay, I think that's all right. We will go. So we won't have the results. So now I'm asking this question for a well-informed oncologist, and there are different definitions of well-informed oncologist. But anyone, I think most people in India, whether in both corporate setting as well as an academic settings, are reasonably well-informed. Can molecular tumor board provide additional guidance that could improve the clinical outcome of their cohort of patients? So every hospital, you have your own cohort of patient, whether in different settings, clinical outcome. So the answers could be, A would be for 4. Yes, in quite a few cases, rarely if ever. And you can say, well, for me, it is an abstract concept. I really do not know. So whichever A, B, C, I've not written A, B, C, you could choose your responses. And the second, if you, the first answer is precision N of 1 strategy, NGS driven medicine. Do you believe in it? Answer could be, A is not sure what it means. Yes, in principle as well as in practice. And C is theoretically appealing but hard to implement or get benefit out of it. So, okay. Now I'm just showing. So I was surprised there has been a systematic review of the clinical outcomes of molecular tumor boards. So molecular tumor board is different from other, multidisciplinary tumor boards we have. We also have, in addition to all the oncologists, also genetic counselors, radiologists, pathologists, pharmacists, and basic scientists. So that they are also important. The question on the there's limited data on the clinical utility. Is it exercise in futility or the patient's benefit? Is it worth time and effort? So actually what this was found, that there were 14 studies, and they found that there is actually benefit in patients who receive the molecular tumor board recommended therapy. That significantly better PFS as compared to those who received conventional therapy, just whatever physician choice therapy. So this looks like, I'm not sure, but this is limited data. Then this recent paper which came, real world data from molecular tumor board demonstrates improved outcome with precision N of 1 strategy. That means, so there was 429 patient on whom 265 had a therapy evaluable, matched drug. And so they were either, some of them finally the physician decided. So under a master protocol, either physician used his or her own way of treatment, or the molecular tumor board recommendation. And what they found, that patients in whom were treated by the MTB's recommendation, they did better. So that is one thing. But of course, I think there's a little bias there, because whenever the MTB comes with an unequivocal recommendation, it will also appeal to the physician, and they will use that. So you know that they are very classical cases, but at least it shows that we don't confuse and overtreat, and more patients don't die. Sometimes there's a possibility that just because you do more, you might be killing patients. So that is one thing. But the N of 1 oncology, look at this Pembroke keynote 158. So the number of prostate cancer patient was just 1 or maybe 2 in these patients. So you say, but because you have called it all as non-colorectal high MSI tumor, they have all clubbed together and you get a data of all the patients. But the response rates you look at, so for endometrial, which is a classical Lynch syndrome, the OS is not even reached. It is more than 27 months to not reached. Whereas for pancreatic, it is just 4 months and median PFS. So what you can derive when you say N of 1, it is histology agnostic, tumor site agnostic. But when you look into the data, I think it is still a long way when you can say, just in this one patient, what I have found, I will use that. So you use that very important information, but you have to go back and see the studies, larger studies from which this data was there. So maybe any of the experts here from Dr. Anita, would you like to say N of 1 strategy? Are you in this? Do you believe in this concept, or do you think it is just hype?
Yeah, it differs from tumor to tumor. We cannot generalize everything.
Okay.
Some are quite responsive. Yes, molecular MTB tumor board, genetic counseling, doing an NGS, as in India, will help a small section of the society. But if you ask theoretically, I would love to do as per the guidelines, but I'm not able to do for most of my patients.
So that's a practical. So right now we are not talking
Discussion.
because
Yeah.
the issue is what to do. Then next can we do it or not? The practical aspects of logistics. I'm not getting into logistics now. I'm talking more of, because the clarity first, the physician has to have clarity of thought. Then only we start looking at as to what is it.
Yeah.
So maybe from the last, the panel 3, just any one of you would want to comment utility of molecular tumor board or N of 1 concept.
So I went through the paper after I saw that. So the paper was very nicely written. It signifies that every patient has got a different molecular signature. So the physician gives n number of options that is apt for that particular patient. But again, molecular tumor board goes through all the molecular reports and then they decide that yes, this is the best option. Then the physician gives a concurrent that yes, I agree with this option. I do not agree with this option.
What is your personal this thing? Do you agree with this N of 1 concept, or it's just?
I partly agree to that, because still physician is given the maximum respect in this board, as we have seen. And whenever there is a discordance, then they go back again to the physician. But it is yet an evolving concept from India.
Okay. And I think everyone is learning. I think in 5 years' time, the molecular tumor boards will be much more, emphatic. Yes, no, or they won't fall into the traps. And there's so many. So now I'm asking this question. Now this is now coming for prostate cancer. So that was still general. Now for prostate cancer, many of us, treat many sites, and prostate, we were not traditionally doing this thing. Now certainly the NCCN and papers in JCO, one after another are coming. So if you all want to vote, if your voting system is working well. So clinical context, when genomic or genetic analysis in prostate cancer patient is relevant to decide either risk stratification for conventional therapy, whether you give them or not, or just surveillance, and as well as precision therapy. So germline is multi-gene panel, including homologous recombination repair pathway and MMR genes, tissue gene expression, RT-PCR transcriptome like Prolaris, ProMark, Decipher, Oncotype DX for prostate, and or tissue and liquid biopsy multi-gene mutation analysis, which is a somatic with or without MSI for tumor mutation burden and androgen receptor V7. So for screen detected low risk prostate cancer at diagnosis, what would you say? A is little or no role, B is some role, C is major role. So if you have done your voting, anyone, maybe table 2, what would you, A, B, C?
For in screen detected low risk, actually little or no role.
No role.
Yeah.
Okay.
As we proceed further, when
Yeah.
there is,
I think in our country, it is no role because we get very few screen detected prostate cancer, unlike in the West, where there is a flood of screen detected asymptomatic, you really do not know. So where they look at if patient has more than 10 or 20 years. If it is very low risk, more than 20 and life expectancy, low risk, more than 10 years, then this helps you whether you treat them in active surveillance or you actually treat them with monotherapy or with multiple therapy. So this is fine. Now, intermediate risk prostate cancer at diagnosis, robotic surgery done. So in that patient, is there any role, table 3, any one of you? Is there any urologist here in the audience? No, we have ignored them. Any one of you? No.
For intermediate risk, I think there may be some role, depending upon if there is family history, what is the histopathological presentation.
Yeah. So if there is family history, high risk, if patient has high risk prostate cancer at diagnosis and has had ADT and radiotherapy, on
Then yes.
high
C,
risk,
major
yes,
role.
yes. So major role. Now metastatic castration naive prostate cancer as diagnosis. At diagnosis I have, and yes, okay, looks like overwhelming. And now CRPC, metastatic castration resistant prostate cancer.
Definitely yes.
Yes. All are yes. Okay, good. So except for, I think you all have got it right. So I'm just asking for, now I'm talking about the pathway and genes. If you all, if your voting system, is it working? People are doing it, or just, we don't waste time in that. I don't know.
The questions are wrong. The options that are given,
Ah.
they were given as somatic, germline, and this thing for each. It should have been some role, no role.
Okay, okay, fair enough. So we will, because you finally want to get some consensus out of it, or even the diversity of opinion. So same thing, you all can fill it, subsequently, after the meeting, because our time is also running out. So I'm asking, what is your first choice for germline testing for localized high-risk prostate cancer with a family history? First is only BRCA2 and BRCA1, or all the major homologous recombination repair pathway genes, which includes BRCA, or HRR pathway and MMR pathway, or a large panel which have all the genes of possible prognostic or therapeutic relevance, or you find the evidence so confusing that you can't make up your mind. So just, what is your first?
I think B, we should go for along with BRCA1.
First
Yeah.
choice. And if
Yes.
what will be your second choice? Next question is the second best.
D for the larger panel.
Okay. So either HRR, all HRR, or larger panel.
Yes.
This table?
Sir, my first option would be B followed by A.
Followed by A. Okay. B followed by A. The last table? The 3? Anyone?
Perhaps opt for D first. A larger panel.
D.
Cover
Okay. Okay. So really speaking, no one really knows what is the right approach, because unless until we have data on thousands of patients and you have culled, actually now the data I will show later, which actually guides you what you should be doing. But unless until I read those papers, I myself wasn't sure, what's to be done. So you look at pragmatic logistics, what will cost patient more, reflex testing one after another. But now there is data also to talk about it. So the first and second choice we have discussed. Now we are talking about germline testing in metastatic. So would it be different? So initially was localized, now it is castration naive. Any one of you would have a different approach for germline testing, or same?
Sir, in last question, what is your choice?
My choice. I will talk later, because if I start talking about my choices. Okay, so my choice originally would have been D as the first thing, but after reading the paper, I think the HRR pathway genes, because see what you want to do C covers basically everything, or your immunotherapy, because 3% patient may have MMR gene pathway, and remaining 8 to 10% patient may have HRR pathway. They would cover everything. But really speaking, if you look at the data hardcore, it is only the BRCA2 mutation which is making actually major clinical difference. Okay, so if someone is doing only BRCA2 and BRCA1, I can't really argue with them, very hard. Based on data, I can't argue with them much. In terms of their intention is only clinical benefit for patient, nothing else. Okay. So I think we have covered this thing. So in castration resistant as well as castration naive. So I think most people would use the same approach, or in different settings you would do different things.
So probably in the intermediate risk we look into the pathology as well. We look into whether there is a intraductal or a cribriform. And when it comes to a localized high risk, then we go for means BRCA2, BRCA1. But when it comes to metastatic CRPC, we are a little bit go into a larger panel like HRR, MMR, and other therapeutic evidence. So we go extrapolate from the trials.
Because by that time, there could be other things also. It may not help you in therapy, but maybe sometimes prognosis or, that also allows you to calculate tumor mutation burden and all.
But perhaps the tendency, the Indian mindset as such, they would do the testing only once. They may not, agree for cascade testing one after the other.
I think that is also a very important point because patients already spent, pehle kyun nahi bola? Why you didn't tell us earlier? So that I think is an important mindset of the patient. I think very, very quickly, let us go through. Now for somatic, okay. Now the issue comes, will you do only BRCA 2 and 1 or again the same thing is. So which one for somatic table 1? D. Table 2 for somatic if you have to.
Somatic first and then.
No, if you are doing somatic, I'm not saying somatic or germline. So which one, D panel or C or B?
This is for breast cancer or prostate?
Only prostate we are talking now.
Acha, family history of breast.
Patient prostate cancer with family history because they run together. Okay. So I think in the clinical setting, again, the data, very few people have done only BRCA 2 and 1. In somatic setting, most people have had a larger channel, at least all the HRR genes, 10 or 15 genes. So the comparative data is not there, but I think it is pragmatic to do a large panel, including all as many, because they won't develop for you prostate cancer specific panel. I think we will just go through it. Now, I'll just show you, this is systematic review of the prevalence of DNA damage gene mutation. So they had looked at the prostate cancer, and this is from the germline mutation, and the green one is somatic mutation. By doing somatic, you identify more mutations. And in metastatic CRPC, of course, when you do somatic with a larger panel, because you will identify more mutation. And this is in ATM and it is in BRCA1. But if you look at the most important gene is the BRCA2 gene, because in terms of response for prostate cancer, in prostate cancer, whenever the BRCA2, the most important gene, whether you do germline or somatic, the number of mutation prevalence is same, because BRCA2 is the real gene which is actually the driver for hereditary or inherited genetic type of prostate cancer. So if you want to catch the real gene for therapeutic benefit or for everything else, then whether you do germline or somatic, there is little difference. But if you want to get a full spectrum of the HRR pathway, give the patient the benefit of PARP inhibitors and all, for whatever its benefit it is, then of course doing a larger panel. So now I'm just showing what the NCC, and if you look at germline testing, it recommends for almost everything, for very low risk to low risk. So you recommend, of course, in very low risk and low risk, if there is a family history, and otherwise, whenever there is when it comes to intermediate risk, when there's an intraductal histology, and in intermediate, and of course, high risk, irrespective of anything, you do that. So almost, and in our setting, we get very few very low risk and low risk patients. So in our setting, it is recommended, it will become almost every second patient, and all pathologists, unless until they are uropathologists, uro-oncopathologists, they would not necessarily report on intraductal histology. And many of us as clinician also, we had not earlier given enough weightage to the intraductal histology and were not asked, and they had not reported. Whereas for somatic, so this is for somatic biomarker analysis. For low risk, deciding whether you need to do active surveillance, you can do, or you have to treat the patient. That is where it is required. And intermediate, because it can predict what will be the outcome, what will be the histology based on your robotic surgery. Because patients need to decide, if I undergo robotic prostatectomy, what are the chances I may still require radiotherapy or may have other things. So this is where it is coming. But otherwise, what we have been thinking, a patient has metastatic. So this is localized prostate cancer, not metastatic prostate cancer. It is not there. So NCCN guidelines, I've just sort of summarized. Basically, anyone who has a family history, which is a high risk or very high risk, or a metastatic prostate cancer, Ashkenazi Jewish ancestry, because they have a higher intraductal histology. And whenever germline testing is to be done, they recommend that all the Lynch syndrome genes with the mismatch repair and the homologous recombination gene, they should be checked, at least these genes. So this is, I'm just giving what a genomic test result for prostate. So fortunately, we don't have to deal these men who are very anxious more than them. Then sometimes the wives are very anxious how whether my husband should be treated or not. Is that it tells you either active surveillance or use a single modality treatment or multimodality treatment based on what is the likelihood of this patient having a disease specific, whether the chances of dying from the prostate cancer. So very quickly, I'll take you all through a survey of urologists and uro-oncologists in US, and actually revealed major gaps in knowledge and practices regarding germline testing for that. And this had come after the NCCN guideline, which was widely publicized in US, and even urologists see the NCCN guidelines. I think everyone sees that. And was it because of lack of knowledge or access to genetic counselor, or they were not convinced with the ever expanding indication of germline testing for prostate cancer from not just NCCN, but others also have done that. So we want to know what the Indian oncologists think about the practice. So this was the question. I mean, I don't have time to do that. So this, they had asked the question. So this is a guideline. Testing is clinically indicated for metastatic prostate cancer at any age, with family history, without family history, and metastatic prostate cancer with BRCA mutation in tumor profiling somatic. So whether you would do germline testing, yes or no, or don't assess, say, well, I don't deal with this kind of patient. So table number 1, the tumor board 1. So metastatic prostate patient with family history of like a classical HBOC, you will do. Anyone who says no, they won't do. No.
Yes. Again, if you take it as a real scenario, then the answers are different. Theoretical, yes.
No, they're asking in your practice, at least you would refer. You may not do it, but you may refer. So
Practice changes from place to place. Because even a medical college, I will not do, sir. I don't have facilities, logistics not in place.
no, but
Any-
if suppose that was not there, you would have wanted to do.
Yes, then I will do. So
Yeah.
it differs practice to practice where we are.
See, the other thing is now, we are not referring. Okay. So suppose someone has a metastatic prostate cancer and a strong family history, you may not do it because patient can't afford. But if you have not raised that query, you have not even referred. Today, the patient may not be there, but 5 years down the line, the patient's daughter may come and catch you that this is a classical HBOC and did not advise. And today I'm sitting with advanced ovarian cancer. Yes, Amit, you want to say something?
I think, sir, in metastatic condition, at some point of time, every patient will become CRPC. So counseling or dialogue should be started when the patient become metastasis, so that you may need it at the time of progression of the disease. The report, because report will take another 4-6 weeks to come sometime. So what I do practice, at the time of metastatic, when the patient becomes, we usually discuss and at least send the somatic sample for, because by the time the
You're right. So recently we have started getting prostate patients for, for testing. So that is good. So I won't see, there are many questions they have. I will directly show you the results finally. So now this is germline testing for high risk localized prostate cancer. So they are high risk, and high grade, no family history. And then when they have brother died of prostate cancer, so it becomes familial. Then it becomes patient has high grade Gleason score with the Ashkenazi Jewish ancestry. Then it is a individual, clinical event patient with first and second degree blood relatives with, HBOC type of cancers or intraductal prostate. And the last is a patient with a known pathogenic variant in a cancer susceptibility gene. Okay. So I will now directly show the results of this. So this is the US radiology. So this was a survey they did. And this is after the NCCN guidelines. What I've highlighted, that the patients where you have a metastatic prostate cancer, even if there is family history, 14% urologists or uro-oncologists saying, no, I won't do it. I think because they are not comfortable talking to that family if something comes up, because, they are not there. They're there to remove prostates by the robot, not to talk about these things. So it's a comfort level of the physician also. And they haven't faced lawsuit. These families haven't come back to them. And metastatic prostate cancer, BRCA on tumor profiling, about again 2/3 say. So, and you see about 1/4 of all these, urologists or uro-oncologists, they are not even comfortable thinking about it. They say, well, we don't assess. Okay, forget about taking a decision. We don't get into this. Okay, so this is the reality of 2020 urologists and uro-oncologists in US. So if you all don't do it, don't feel bad. But of course, we have to improve things. So there are certain patients, if you don't do it, there could be consequences for the patient, for the family, and sometimes for you also. So this is just it. And again, so intraductal. So only 12%, majority feel that it may be intraductal, I don't care. So there are papers which shows if it's an intraductal, there's a high chance of germline mutation. But as of now, this knowledge either has not percolated or they know it, but they are not convinced that because they have been seeing intraductal histology in so many patients. You know, this is to call it pins and other things. So they are not convinced. So now I'm asking this question, the yield and concordance between germline, archival tumor tissue, germline, archival tumor tissue, and liquid biopsy, cell-free DNA. So the chances of finding the most clinically relevant genetic alteration, which is the best one, germline testing on blood sample, somatic testing on archival tumor tissue, liquid biopsy, or there's not much to choose between. And then again, I'm asking, the first is the most clinically relevant. When I say most, means most, which is the most important. And the second is maximum number of clinically relevant genetic alterations. So both the choices. So number 2.
When you talk of most clinically relevant, actually it will depend upon the sample platform use techniques, because there is a bias when we do NGS.
Yeah.
When we're doing NGS test on the tumor tissue,
Yeah.
Things are different. And if you extract DNA from the blood and do, that is the easiest.
Yeah.
So
Technically, the result that you get is much more.
From blood, it will be maximum clinically relevant, as well as most clinically relevant findings will come from germline.
Yeah.
If you have a good technique to extract DNA or RNA from the tumor tissue, then things will be different, of course.
But all these are clear approved tests, and they are run in this. All the results that I'll be showing you, they have been done in not in a research setting, but in clear approved labs. So that's what I'm talking of. So what you see is, I'm just quickly show the results because we have. So this is the concordance. The green ones are concordant, and the gray ones are partial concordance, and the red ones are discordant. So 72 men with DNA damage response alteration, primary samples with paired circulating tumor DNA and or metastatic tissues were sequenced. And primary tumor represents action. So I'm not talking of germline versus somatic that I had shown earlier in the earlier slides. So, which is actually, it is revealing to me also that the primary tumor represents actionable mutations, which is retained most. Again, BRCA2, if you look at which is the most important gene, as we have shown, I will show a slide later. There were only 1 or 2 cases where the primary tumor archival tissue had missed a BRCA2 mutation, which was picked up by circulating tumor DNA or by other method or a biopsy from the metastatic cancer. So if sometimes we feel bad, okay, there is no biopsiable lesion, we have to use the old archival tumor. Of course, in our country, the way it is fixed and stored in paraffin embedded, everything that could alter. So this is for US, the way histopathology is done there. I do not know what will be the findings there. So I think some of us should, those who have a large practice should do that. So in deciding, I think I'm just coming, we have less time. So in deciding therapy in castrate, now we're talking of the CRPC, which is the most difficult. So which one would you give major consideration, minor consideration, or no consideration at all? So one is BRCA2, BRCA1, other HRR genes. Just few minutes because we lost in this technology. MMR genes, high TMB, androgen receptor gene, or BRCA1 to reversion mutation. So just number 1, what will be your most important? BRCA2. I think I've already said that so many times.
Yes,
so I think there's
next is BRCA1.
next is BRCA1.
Then is HRR, then
Okay.
MRR.
Okay. So again, I won't go into details of, so people only talk about PARP inhibitors, HRR for PARP inhibitors and MSI or DMMR for, immune checkpoint blocker. But at least the real world is a little different. If you look at in this study, what they looked at, prospective cohort study of impact of germline DNA repair on the outcomes of CRPC. And In this, what they found, they were looking at, just look the last line you look at. So some patient had either a germline mutation or do not have germline mutation, in which BRCA2 significant interaction between germline BRCA2 status and treatment time. So androgen signaling inhibitors versus taxanes, both cause specific survival. So if they had a germline BRCA2, they did much better as compared to if they did not have germline BRCA2. So it has real, this was in JCO, a couple of years ago. So look at, when you have a BRCA2 carrier, whereas ATM, BRCA1, other germline DDR genes, whether it was there or not there, in metastatic setting, it did not make a difference. So this is important. Now, this is for, again, we normally don't think. So this was androgen receptor splice variant. So if the variant is there, it truncates the protein. So androgen receptor is not there for binding. And in what they found that in metastatic prostate cancers who were started on abiraterone or enzalutamide, if they had a truncated ARV7/2 CTC methods, one was John Hopkins, other was, I forget the name of that. And both of them correlated strongly with progression-free as well as overall survival. So this is something which you don't always think, we don't have access to, but something which could make a difference. Then even for patients who have radium-223, it made a big noise, big splash few years ago. Even them, because how it works, radiation works, they had much better overall survival if they had a germline mutation. Just last slide, I would say, racial difference. All the data is from West. Even in somatic, we think germline could be different. Even at somatic level, if you look at copy number alteration, there were major difference between different races. African Americans, we know they have early onset and more aggressive prostate cancers. They die early also. They're generally not put on surveillance. And even the tumor looks very different, the copy number alteration. So how Indian men that our prostate tumors would be, I do not know. Something in between Caucasian and African Americans, we have no idea. So there is need to produce our own data. This is my last slide. And just any one of you could say, what would you do if your patient does not have access to or not willing to go for expert genetic counseling? You feel this patient should need detailed genetic counseling, lot of issues, but they won't go, or they just don't have access.
Document it. And allow him to choose what
so
he
your
wants.
point is documented. I think we can
And
close
let
the
him
PPT.
choose. Let him choose what he wants to do.
Okay.
So
So
online genetic consultation nowadays is
online, yes, that is one thing. But again, see the patient and the family, it works very well. Telegenetic counseling.
Doesn't want online.
No, they may, but so there is an option. So earlier we never used to have that. So online is one thing. Any one of you?
One more thing, he may not want, but this next generation may be wanting. So we
No,
call
you are
this-
talking to the patient who's in front of you. The
No,
next
we call
generation has
him,
not come.
tell your son to come or something.
We can just stress the importance. That is one. It should be documented.
Okay. Yeah. What are you saying?
Thing is that we should stress the importance of this counseling to that patient.
Yeah.
That should be documented, one. Because he may not be interested at that point of time due to n number of reasons. But if he understands the importance, he or his family will come back, and there are
Agree.
relatives and family at risk.
Agree. Most of the lawsuits have been by the family member of the deceased patient, because they say, I am getting this major surgery because you did not tell my. Now, one thing, mainstreaming of genetic counseling and genetic testing, there's no way any oncologist cannot escape. So you have to learn the basics, and at least at basic level counseling and advice about testing. This you just cannot escape. Maybe 2021 you can escape, 22 you can escape, 2023, 2025, no way. Some of us will retire, we will probably go away, but all the youngsters have no way but to get into mainstreaming of genetic testing. Thank you.